So I will talk to you about the hernia registries because I believe they are a very, very important tool for improving quality of care in our everyday life as abdominal wall surgeons. These are my disclosures. So why are you in Jaipur, and why are we discussing all these very, very intriguing and interesting items? Because we are dealing with the safety and the healthcare of our patients. And everything we do has to do with value, which means increasing the quality at a lowest cost or at a cost as low as possible, because then we will do the best for our patients. Now, do we need to improve hernia surgery? How are we doing related to publications or related to data from registries? Well, when I grew up as a young surgeon 20 years ago, this was what I heard always around. The hernia was put at the end of the list. It was for the junior surgeon. You should not worry too much. You just take care of it and it's done. And it's, of course, nothing compared to complex colorectal surgery, bariatric or HPB surgery. However, we all know that also hernias can give dreadful complications. And you are discussing them in Jaipur yesterday, today, tomorrow. We're talking about recurrences. We're talking about chronic pain, but so much more, just like we heard in the previous session, like sometimes very dreadful chronic mesh infections. So we can do better. And I will give you two examples from the literature on very, very unimpressive pathologies, like this one, the small umbilical hernia. What is the big deal? Well, if we look to this paper from Denmark, from the Danish hernia database 7 years ago, they looked at very, very small hernias, as you can see, smaller than 2 centimeters. And they looked at clinical recurrences and reoperation rates on the long term. And the data, as you can see here on the left side, ladies and gentlemen, with a follow-up of 60 months, 5 years, are very impressive. Almost 20% of the patients gets a clinical recurrence or is reoperated if you start looking very closely to your outcome results. And this is astonishing for such a uncomplex, very simple pathology. Another example, which is, of course, very much more intriguing, it's the parastomal hernia. We saw beautiful lectures this morning on robotic surgery, but did you know, also again, data from the Danish hernia registry, did you know that there is a 25% risk for 30-day mortality after emergency repair for a parastomal incarcerated hernia in a very developed country like Denmark? We have no reason whatsoever to think that in the States, in Europe, in Belgium, or whatsoever, we would do better than that. These are dramatic numbers, ladies and gentlemen. So we can do better. And I will just try to run in the next 20-25 minutes with you over some ingredients to do better in surgery or hernia surgery in particular. This is, of course, a mainstay. Why we became a surgeon, we need to master an excellent surgical technique. Difficult to learn in the books. Internet helps, social media help, but this is, of course, the mainstay of what we are doing from day to day. Guidelines can also help, of course, because they have summarized the literature for us by a group of experts and are free to use mostly by open access. But we also know that a surgeon is a very, very special human being. And it's often very, very difficult to change the mentality of the surgeon who says, I know what is best. I know what to do. I have always done it like that, and I will keep on doing it like that. So changing the mentality of the surgeon is not an easy one. And many surgeons say, I do not need guidelines. I know what I'm doing, and I don't need any help from outside. And these surgeons, ladies and gentlemen, these surgeons need to be challenged. Challenged on their question or our question to them, do you know how you're performing? Do you know how you're performing compared to your peers? Do you do a regular audit of your own data? Because if you don't measure it, you cannot improve it. That's clear. And this is, of course, ladies and gentlemen, where the registries come into play, because registries, not only in hernia surgery, are a reflection of the real world. And you see it's booming everywhere. And on the left side, I show you Erik Nilsson. It's the guru, I could say, from starting the Swedish hernia registry more than 20 years ago in Sweden. And he was really the very, very first person who started with this idea in hernia surgery. We all know that in the pyramid of evidence, randomized controlled trials are really on the top. And I will not go into detail. You all know why they are considered as level 1 evidence. However, we all know that prospective studies, high quality registries are necessary to add data to the literature that are gathered with randomized controlled trials. Why? Because they offer a high external validity, and it is very much possible to study rare events, which is very difficult, of course, in a limited number of patients in a randomized trial. So as a matter of fact, I strongly believe that the best data are a merge of data coming from randomized controlled trials, often in very ideal situations, and data from prospective registries. Another benefit of registries is post-market surveillance of medical devices. We all know that the problems we sometimes see or have seen with medical devices, it's only the tip of the iceberg. I show some data here of all different companies that have withdrawn material from the market because they did not perform well. However, there is probably much more hidden behind, under the water, that we don't know because it's not reported. And this is why the new EU medical device regulation, which is just started and in May 2021, so 1 year ago, and is now in a transition phase until 25, will probably increase the quality of our outcome performing. And why is that? Because this regulation now states that all surgical meshes we use become high-risk devices. Patients will have implant cards. Trials will be needed, both pre and both post-marketing. And again, there will be a very important role for high-quality registries from surgical societies, because again, they are a reflection of what we are doing in everyday life. One example that probably you all know, the laparoscopic IPOM for incisional hernia with the physio mesh. Well, there were 2 papers on the left one. On the left side, the paper from Köckerling and his group on hernia mates published in the Annals of Surgery. And on the right side, the data from Helgstrand from the Danish hernia database in the British Journal of Surgery. And both of them showed that recurrences after 1 year or after 5 years on the left and on the right were significantly higher with this type of mesh. And in the present case of physio mesh, it were these data from hernia mates and the Danish hernia database that led to the voluntary recall of this mesh by the manufacturer. So they have a strong power if the research is done properly and if the numbers are high enough. You have been discussing this morning all kinds of new techniques of minimal invasive extraperitoneal placement of meshes. And we all know, this is a nice paper from Poland in 2020, that there are so many different minimal invasive techniques and it's booming terribly. But it's very difficult to know exactly good indications and what are the exact outcomes of all these new techniques that are running around now. Well, this is again an important place where registries are coming into play, because they will allow to look at case-matched comparisons of all those different techniques compared to the gold standard, which is still, in many cases, the open vitreomuscular approach. But of course, this is the key question. Does including patients in a registry improve quality of care? And again, I come back to Erik Nilsson, who wrote already in 2012, so 10 years ago, that registries may improve quality of surgery. Why? Because they give individual units and surgeons easier access to their own outcomes. And why is that? Well, ladies and gentlemen, this is because of the so-called Hawthorne effect. And what does it mean? Well, you will perform better if you know that you are being observed, if you know that you and your peers will look at your data later on in a constructive way, you will know that, or you will automatically, to say so, perform better. Many data from the literature, this is a review paper in surgery in 2015 that showed that taking part in a quality improvement program in the States decreased mortality, decreased morbidity. This is not, let me be honest, this is not specifically in hernia surgery, as I have to state. But, and please have a look at this paper that was published in Hernia some time ago, there are risks and pitfalls when looking at data from large registries. And that's the second part of my lecture. It's not enough, in other words, just to participate in a registry. And I will try in the next 10-15 minutes to tell you some keys to success to develop a nice, good registry with minimal risk of bias. This is the very first one, ladies and gentlemen. All surgeons treating hernias should participate. So we should make it easy for those surgeons to participate. Don't say, this is not for me. I know what I'm doing. I know my data. So this is really not the way to follow. All surgeons need to participate, and more importantly, they need to include all consecutive patients. No pre-selection a priori. So this can be done voluntary or compulsory, but of course, surgeons hate the word compulsory. On the other hand, I think when you really want a consecutive inclusion of all patients, there needs to be a certain incentive to include your patients compulsory. And if you don't do that, and you work voluntary, you need at least a good screening log in every center to see how many patients of the potentially included patients to be included were really effectively included in that center. Is it 95% or is it just 3%? Because of course, this really makes a difference. Another important part, and I took this slide from my good friend Philip Muisons, is look at the whole picture. When you make the concept of a registry, try to think broad. Look at all different risk variables that might play a role, both patient-related, procedure-related, and prosthetic-related, and really define very, very well your outcome measures. I will come back to that in a second. And more than that, don't just rely on the input given by a study nurse or a surgeon, but do some form of source data verification, because this will enhance clearly the quality of your registry. If you know that the data are correct and are really reflecting what is written down in the file. Maybe this is even more important, ladies and gentlemen. Keep it simple for patients and surgeons. And let me first talk about the patient. The informed consent process should be simple. Make them part of the group. This is why we're doing it. We want to improve the quality of care of our patients. So give them some patient empowerment. Make them part of your steering committee. Make them part of the group. And they should take into hand the follow-up. And I will come back to that in a few moments. For the surgeons, it should be a very simple, preferably electronic, of course, surgical registration form. All data that can be inputted from administrative or demographic sources should be done automatically to take away the burden for surgeons to do that. And if you make a report in your registry, a surgical report, this should go back to the EHR in order to avoid the surgeon to give a double input of data. And please try to take the follow-up out of the hand of these busy surgeons in Jaipur, in India, in Europe, in the USA, or wherever. Let me give you one small example with a few hints on what we have done since 5 years in Belgium on inguinal hernia. I know it's a 15-hour flight between Jaipur and Leuven. We started 5 years ago. We included 18 hospitals, all member of the same network. So we use the same electronic health records. It's a voluntary participation. And this is, as I just mentioned, this is the mainstay. This is the backbone. A very simple electronic operation report. I just show you one slide because of time constraints. And as much as possible, data from the electronic health record, like the patient data, the date of surgery, the operative time are automatically inputted in order to avoid bias by not giving the exact timing, for instance. And secondly, to avoid the surgeon to spend time to include those data. Another important, or maybe the most important bottleneck of a registry is the long-term follow-up. Because if you can't follow up your patients, everything we have done does not make sense. And so you can rely on clinical outcome data, but it's difficult if the surgeon has to give the input because the surgeon will forget, the surgeon will not do it completely. So it's probably much better to rely on an automated or a semi-automated data acquisition. And how can this be done? Well, I will give you two examples. Of course, patient questionnaires directly coming from the patients and administrative data that the hospital has to develop anyhow on outcome, readmission, reoperation, and so on. But let me go back to the left side, to the digital patient questionnaires, because indeed, patient-reported outcome data should currently, in 2022, be part of your registry outcome data. With Likert scales, for instance, let's not forget a very important outcome factor, which is often forgotten still now in hernia surgery, and this is just simply patient satisfaction. It's very, very often forgotten, and it's a very, very simple question. And especially now, of course, with the handheld devices, patients are able to log in to their electronic health record or to their PROMS questionnaires everywhere in the world. Example from our inguinal hernia registry again. We started 4 years ago with as primary outcome parameter the incidence of chronic pain, and we try to follow up the patients up to 5 years post-operatively. These are all the secondary outcomes, you know them, 30-day outcome, satisfaction, recurrence, and so on. And this is how we do it. These are the time points. As you can see on the left, the preoperative inclusion with the help of a lot of validated questionnaires that you all know, inguinal pain questionnaire, Carolina comfort scale, and you see patient satisfaction is measured pre-op and post-op up to 5 years post-operatively. Another important one, I keep on saying the same thing because they're all so important parts of a good registry, ladies and gentlemen, is to keep the enthusiasm of all participants, both surgeons and patients. And for surgeons, you need really a time spirit. You need to give regular feedback, constructive feedback, and allow discussion within the group. The ownership of data should be held by the group of surgeons, the organizers themselves. You can offer them certificates of participation if you believe this is helpful. And of course, they will be included in publications and presentations. Just again, some examples of a dashboard online, accessible day and night for our surgeons to do some online benchmarking on the inguinal hernia registry that I just proposed to you. We included now almost to 2,500 patients. As you can see, these are data that every surgeon can see from all the different participating hospitals. Here you can see that every bar is a hospital, that in blue is a top or TAP, and you see that we are a top or a TAP country, to say so. So the large majority is done by minimally invasive means. This is the pain score at 1 year post-operatively. Green is no pain, light orange is mild or moderate, and in red is severe pain at 1 year post-operatively. You see we have to work on data completeness, because now after 1 year we have only around 50% of outcome data, which is clearly insufficient. And as I just mentioned to you, and this is still an important slide with only 50% of outcome data after 1 year, you see that around 5 to 10% of patients are unhappy after 1 year. And of course, this number will be lower if all the rest is green. I'm truly aware of that, but still, if the numbers, and every man in 4 will develop an inguinal hernia. So my point is, if you measure it, you will see that some patients, for pain or for other reasons, are unsatisfied after 1 year. And this is exactly what we have to decrease. So let me slowly finish up by saying this is what it is all about. It's a slide I took from the literature. It's data going from your center, from your surgical service to the central database. The central database gives feedback to your surgical department, and this will lead to a quality improvement. But again, as I said, the feedback that is given should be constructive, should be timely, should be specific, and should be objective, because otherwise everything is doomed to fail and there will be no long-term sustainability of your whole endeavor. And of course, then you can start benchmarking for setting targets for quality improvement, for discussing in networks, and possibly also for certification. Don't forget to maintain the enthusiasm of patients by sending them reminders, by making the questionnaire bulk more simple in 2 levels. What do I mean? If the patient has no pain, it's not relevant to send 5 or 10 extra questionnaires if the pain is absent or minimal. Provide a help desk, provide video clips with patient testimonials, what we have done in Belgium, and again, try to include patient organizations. I will stop by, of course, showing one very nice example on ventral hernia registration from India. I took it from the last online issue in August in hernia this year by the group of Dr. Baik. And I think it's a very, very good start with including all elective surgery in adults during 3 months in 2021. And I took out for your illustration the data on incisional and recurrent incisional hernia. Very impressive data with 45 centers and 75 surgeons. The mean defect size was 5 by 5 centimeters. TAR was done in a minority of patients. You see that 30% of the cases, which is 90 patients, were operated by only, which seems to be very popular in India. And the follow-up was still very early, but at least a minimal follow-up of 3 months with a median follow-up of a bit more than 4 months. And these are the outcome data. As you can see, very interesting to look at, because there was a small mortality, which was within 3 months, not directly related to the surgery, but still important to state and to compare, because if the patient was not operated, maybe the mortality would have been lower. And as you can see below in the slide, the Clavia and Endo classification, grade 3 is reoperation. So a reoperation rate within 3 months of 2.2%. Again, not very high and truly acceptable, but it's important to have those data and to compare them to do better in the future. So I think, when I'm correct, that indeed, like the authors write in their discussion, this is the very first study from the Indian subcontinent to try to capture the variation in practices in the field of hernia surgery by means of a high quality registry. And as you can see, there is a discordance between the guidelines and the current practice, where onlay is very, very popular. And it's one of the tasks, and I think the goals of these authors, to look more deep in the results, comparing onlay and sublay to see if quality can be improved in the next few years. But again, congratulations to this group of gastrointestinal endosurgeons on this wonderful initiative. Of course, I cannot stop my lecture without including one slide on Big Brother who is watching you by means of a registry. And all health authorities in Europe, in the States, in Asia, in the Middle East, are moving from a volume-based to a value-based type of healthcare. And so, of course, they are interested in those data. But it's very important to state that we are discussing here peer-controlled research initiatives. And this is a very important point. And even this is more important. These data can be very interesting, of course, to payers, to healthcare organizations, and definitely to surgeons and patients. But I strongly believe we as surgeons in the field need to take the lead and be the owner of our data, and not vice versa. So let me come to an end. Dr. Bandarkar, Dr. Bajal, dear friends in Jaipur, I strongly believe that high quality systematic registration is really a must in surgery. But we need to minimize bias, especially in inclusion and follow-up. We need to minimize workload for surgeon and patient. So thinking on that, at the start or before the start is very, very important. The consent form should be very, very simple, and feedback to surgeons and patients is crucial to maintain this team effort and to maintain enthusiasm of the group. And last but not least, I'm a very big fan for linkage between different registries, because then it really starts being interesting. If we can compare data from Denmark, Belgium, India, the States, and so on, to make sure that the quality of our hernia care all over the world will do better in the next years and in the next decennium. Again, ladies and gentlemen, I'm very, very humbled. I thank you very, very much for being able to give this Dr. H.G. Oration lecture. And I wish you all the best for your today and next day at your wonderful place in Jaipur for the Hernia Society of India meeting. Thank you very much.